Okay, welcome everyone. And I want to welcome you to this session that is sponsored by Elixir Medical. And we're going to deep dive into the Rev A Hertz Contact intravascular lithotripsy. Could we achieve more in calcium modification? I want to, first of all, tell you that we want this to be an interactive session. This is a quite new device, so we can expect a lot of burning questions from your side. Use the mics because, indeed, we have a great panel here who do not only perform the trial, the randomized trial, but also have experience in commercial use with this device. This is the faculty, a great panel. So my co-chair is Johan Bennett from Belgium. Then we have Stefan Verheyen, who was the PI of the Pinnacle trial, Stefano Galli, Gregor Leibundut, and Frédéric Bosset. This is what we have on the menu for today. We're going to, first of all, understand a little bit better how this device works. Then we're going to get some insights into the evidence of the so far about the Hertz Contact IVL device, and we're going to have some examples of some real-world cases from the panel. So the course objective is today to learn about this device, the Hertz Contact intravascular lithotripsy system, to review the clinical evidence with this LithiX IVL device from the Pinnacle first trial, and gain real-world insights into achieving effective vessel preparation and calcium fragmentation with LithiX IVL. So I want to welcome here Stefan Verheyen to explain to you how this device works.
Thank you, Valeria. And it's a pleasure for me to talk a little bit about the Hertz Contact intravascular lithotripsy. So this slide actually is only to show to you that this technology has been around for a long time, lithotripsy. I don't need to share you any details, but you are familiar with many of these devices. Basically, what we are trying to do is breaking the stones. That's where the name lithotripsy comes from. So it is designed to achieve effective calcium fragmentation. That's important, without actually injuring the non-calcified tissue. So that's basically what lithotripsy is all about. And as you know, you're probably familiar with the one on the left side, where we're using external sources and energy to deliver energy to break the calcium. But there's also the mechanical one, and this is the one that we will be talking about. And it's all about amplifying discrete physical forces to break the calcium. It's basically a sphere that touches a flat surface that is taking care of the amplification of discrete physical forces causing the calcium fractures. The LithiX balloon that is shown here comes with low-profile metallic hemispheres. As you can see from this animation, it is uniformly distributed on a semi-compliant balloon. And the hemispheres, as I mentioned, the spheres that touch a flat platform break the calcium through these exponential amplification of discrete stresses, and very specifically on calcium. So on the hard tissue, not on the soft tissue. That's why it's not causing any damage to soft tissue. And as you can see from the OCT images, there is a fragmentation and a fracture along the calcium, whether you talk about eccentric, concentric, or calcified nodules. And we will discuss this a little bit later. So here, this slide summarizes basically the physics of the Hertz Contact IVL. And as I mentioned, there's a curved sphere. When that comes in contact with a plane, with a flat plane, as you can see, it will deform. And this deformation depends on several parameters, such as the contact force, the modulus of elasticity, and the discrete area of contact. When you look at calcium, you see there's a high modulus of elasticity and a small contact area, but it has a 6 to 8 times higher force amplification compared to soft tissue, which you see below. Why is that? Because the forces are absorbed and therefore atraumatic. And you can see that it's nicely depicted, the amplification of the forces on the right screen. And to make it more visible and to make this more understandable, you can actually compare it when you hit the hammer on a window. So it's hard on calcium and it's soft on tissue. I always also make the comparison, for instance, if you're with your car on a tire on a mud that is dried up, the flat tire, the tire will actually break the mud, whereas if you're on wet mud, it will just be soft and it will not break. And that's because you have another surface and the energy is absorbed. So this is very brief, the mechanism, and I'm sure that there's going to be lots of questions, but Dr. Bennett probably will discuss and how also the rows on the hemispheres are doing the job. Thank you.
Stefan, don't leave, because I have a burning question I think everyone has in mind now. How this device distinguishes itself from cutting a balloon?
Well, I'm sure it's a burning question. I think everybody may have that question on their mind. But basically, this is mechanical lithotripsy. Cutting balloon is not lithotripsy. Cutting balloon has plates on it, and it cuts through calcium, but also through soft tissue. This is not happening with this balloon. Why? This balloon does exactly what lithotripsy is supposed to do, and lithotripsy is breaking the calcium and staying soft on soft tissue, so not hurting. This is basically what we want to achieve. Why do we want to break the calcium? We want to break the calcium, we want to allow full expansion of the stent once we've done that.
Thank you, Stefan. I think we have to clarify from the beginning, this is a totally different concept from a modified balloon. But now, Johan, please give us some insights into how it works.
Okay, this is show that a bit more clear. So basically, these are the small hemispheres of stainless steel we're talking about here. They're about diameter of 0. Let me see here. Make sure this works. Anyway, you can see them all very clearly. Hemispheres of stainless steel. Depending on the size of your balloon, you will have between 27 up to 45 of these hemispheres, which are uniformly distributed right across the whole balloon catheter. And so you get this discrete kind of, contact with the calcium. And this is where you get this very high level of pressure. And if you want to look at it, you just mentioned there, cutting balloon, it works differently. You've got 2 or 3 blades, up to 4 blades, sorry. But of course, the surface is much larger than the very discrete focal end of a hemisphere. So the pressures you get, even if you go up to 18 atmospheres with the cutting, which we occasionally do, you get about 20 to 30 atmospheres. But with this device, you're getting up to 80 atmospheres when you really have this very focal contact with the calcium. How does it compare to shockwave? Because of course this is what we're really comparing it to a little bit. You have these emitters in shockwave, and you have to, of course, make really sure that your emitter is right at the calcium. As you can see here visually, that is not really the case with a LithiX balloon. You have so many of these hemispheres that you are going to come in touch with calcium. And as I mentioned, up to 80 atmospheres of pressure is observed, whilst of course with the shockwave IVLS, we're thinking about 50 atmospheres. So there's a different mechanism of action with the shockwave and also with the cutting balloon.
Thank you very much. You can also use the chat if you want to drop your questions. And then I'm going to ask Stefan, if you can give us an insight about the result of the Pinnacle trial.
In the meantime, you can also ask questions via the chat, so please feel free, send some questions through and we'll try and answer them if we have time for them.
My task is to share with you what we have so far in terms of clinical data. So what is the clinical evidence for the intravascular lithotripsy using the LithiX balloon? And I'm happy to share data here on the Pinnacle trial, which we carried out not so long time ago. And the trial design is as following. So the objective was to assess the safety and the performance of the LithiX. Remember, this is the first time that we were using it in humans. And the goal was actually to try to treat a moderately to severe calcified coronary artery lesions by applying calcium fragmentations. We enrolled about 60 patients, both in Belgium and the Netherlands. And the lesion length was less than 34, but diameters ranging from 2.25 to 3.5. We had several balloons available, but half of the patients underwent imaging by OCT, pre, post, and final post-stenting. And the endpoint was a primary safety endpoint and effectiveness endpoint, with a primary safety endpoint at MACE through 30 days. But the primary was at 3 days or hospital discharge. The plan was to follow these patients for 6 months, and we had a good follow-up of nearly 100%. If you look at the baseline lesion characteristics, I think what is important to see here and to give away is the fact that we had 80% of the patients had class B2 and C lesions. So sick lesions, sick patients. And the calcified length was about 25 millimeters. Now, in terms of procedural, it took less than 1 hour to do the whole procedure, and the fluoroscopy time was about 13 minutes. So that's short. It's the first time that we're using this. Investigators were not familiar with the technology. But remember, it's actually a balloon that you're using. You don't need an external source. So that helps a lot, of course, in terms of timing. I can tell you that it comes with an excellent safety and performance outcomes, as you can see here. With the angiographic success was 100%. We had very nice angiographic outcomes. And in terms of MACE, it was very low MACE rate, the 1.7. That was due to one patient who had a TVMI, periprocedural with non-Q-wave MI, and also at 30 days there were no additional events. So the clinical success rate was 98%. So with this, the performance goal was met with a huge clinical success. And this is, again, underscored by the OCT data, which are very insightful as to how this works. Looking at several parameters, the minimal lumen area, and also at the maximum calcium site, you can see that the stent expansion at the minimal luminal area is 100% or even a little higher. At the maximum calcium site, we achieve a stent expansion of 103%. And at the minimum stent area, the stent expansion is almost 97%. That's a significant number, because if you look at the expert consensus document, it shows that achieving a stent expansion of more than 90% is extremely challenging, and it's actually targeted to have an imaging-guided PCI of more than 80% for clinical practice recommendations. So achieving a stent expansion of 97% is exceptionally high. And these are just a few examples, and we have other speakers to share cases where they have used the LithiX balloon in eccentric calcified lesions, concentric, and also nodules. But you can see from this slide here that you are able, in an eccentric pattern, by the LithiX to induce several fractures and ultimately have a final very nice stent expansion. As I mentioned, in eccentric, but also in concentric calcified lesions, you see nicely fractures at several spots, and then a final good post-stent implantation. Same goes and applies for the calcified nodule, which are sometimes very difficult, as you may be familiar with. and not that easy. So we often get the question, does it also work in calcified nodules? The answer is yes, and we will also see that in a case presentation. In terms of 6 months clinical outcomes, there were 3 subjects, and you can see there's one subject that I already described. There was another non-TVR, so unrelated to the procedure, and another non-cardiovascular death. So basically very good outcomes. What are the key takeaways? Well, it's obvious that this balloon goes with safety and effectiveness. We had 100% post-stent angiographic success. There's a very low TLF rate, no stent thrombosis. Based on OCT, you can appreciate that we had deep calcium fractures, optimal stent expansion in eccentric and concentric calcified lesions, including calcified nodules. So needless to say that this balloon, which is very easy to use, off the shelf, is in several diameters, it's a safe and effective approach for calcium fragmentation, optimizing stent expansion with minimizing injury to the adjacent vessel. We have not seen any problems occurring distally or proximally in terms of dissection. This is not the case. It offers actually an efficient IVL workflow, and it's a very low learning curve. Thank you very much.
Thank you very much, Stefan. These are great results, and you showed nicely that indeed numbers of fracture was really high in all the lesions, all type of calcium distribution. We know from previous data that the number of fracture correlates also with increased minimal stent expansion. So this is great. But we have some burning question from the audience asking about different type of calcium distribution. So Johan, if you could give us some insight how this device work when we have concentric lesion, eccentric lesion.
Getting there. So let me see, here we're going. So there are a lot of questions which are very good regarding OCT features, the depth of the fracture, nodules, and the paper which is under review will be coming out soon with all the millimeters of how deep were the fractures, etc. Also deep fractures. But I wanted to show you, there's a few cases of eccentric, more concentric and nodular fracture. So here we see one case, as you see quite clearly, a lovely fracture, eccentric calcium there on the top right corner. And after use of the LithiX device, we see fractures. So in eccentric calcification, we saw in the OCT subgroup, 30 patients, 85% of patients had a fracture, at least one fracture. When we look at the concentric cases, I'll just bring you a concentric case here. Oh, I'm just going to have to bring it across. There we go. Even though this is not completely concentric, it's between eccentric and concentric. Again, you can appreciate deep fractures present in the calcium. And in the concentric subgroup, 95% of patients had a fracture identified. 85% of patients had more than one fracture present. And then just to finish off now, I'll just show you the nodular case, which we did. Takes a bit of time to load up here. But I think nodular calcification, I think the whole people, everybody here would agree, is the most challenging case for us as interventional cardiologists. And here you see a nodule here between 6 and 9 o'clock. And I think you can appreciate clearly this deep fracture within this nodule after using the LithiX balloon. There's a bit of disruption at the whole vessel, but again, no perforation, no problems there. So I think for me, the really interesting point of this device technology is that you can apply these small hemispheres right at the point where you want to treat it on the nodule, go up to 10 atmospheres, you're not causing any damage to the surrounding tissue, and you're creating a lot of pressure there at the nodule. So I think it looks very promising. In the 9 nodular cases we had in the OCT subgroup, we had good extent expansion in all of those cases. So I think it really works with the different morphologies of calcium.
Thank you, Johan. Indeed, and most of the time we have different type of calcium distribution coexisting in the same lesion. When we have a severely calcified lesion, most of the time we have eccentric, concentric. So it's good to have a device that would fit it all. But I'd like now to discuss with the panel here. Maybe Stefano, you want to start. How do you think this device may be integrated in your PCI workflow?
Thanks, Valeria. I believe that, say before, Stefan, is a step. If we see a calcific lesion on the angio and we approach with standard balloon or non-compliant balloon and we see a under-expanded balloon, I think that this is the first option to treat the calcium, because it is similar to the balloon, one thing. Second thing, the multiple hemisphere allow to us to have a complete contact against the vessel wall, and it's not a problem if you are a contact in the soft tissue, because it's not big action in the soft tissue. And the second point, then you see probably in the next cases, can we use like a balloon? So step 6, 8, 10, also 12. So 12 atmospheres could be a good preparation of the lesion. And then we go directly, if we check with the imaging, or also without imaging, if to go directly with the stent after preparation and go. I believe it is more familiar than how to do.
Thank you. And Stefan, how about the learning curve to use this device? I mean, you have a great experience within the Pinnacle trial, but how long does it take to get familiar with the device, understand how it works?
Not very long. Actually, a few cases or a couple of cases, and it's one of the main advantages is just a regular balloon, basically, and you inflate it very slowly. You can do multiple inflations. And the balloon is actually very trackable. You can negotiate bends in the coronary vasculature. And I actually learned a lot at the beginning. You were somewhat hesitant, of course. You don't know how this balloon is going to perform. Again, I want to emphasize how good this balloon works, because at the first cases, we were supposed to use a non-compliant balloon, and the first cases we did a non-compliant balloon and then you OCT, and actually nothing happens. The lesion looks very much the same, and when you do a LithiX, you see the fractures even at low pressure. And by doing so, you learn a lot, and you obviously, as we all like to do this, we want to take it to the next step. And so the sizing here also becomes critical. What kind of balloon do you need to take? What is, as we all know, what is the reference vessel diameter? Do we undersize? Do we oversize? Do we use the same 1-to-1 ratio? So this, I mean, over time you learn a lot, and you say, well, basically it's just like a regular balloon almost.
Okay, there's lots of questions coming through here, so we'll try and answer a few of them. One is about the deliverability. Obviously, a very good question, pertinent question. Isn't it a bulky device, the question is? So the crossing profile of the 3.0, 3.5 is 1.2 millimeters. The crossing profile of the smaller ones is 0.92. So really very good crossing profile. The device has a hydrophilic coating on it to make it more slippery. And I must say deliverability is really good. We were looking at some real life cases yesterday, and there was in one case where the whole LAD and circ were actually treated with the same balloon, a 3.0, multiple inflations. So even reusability is very good. So you can get away with one 3.0 balloon in the LAD and circ if you need be. In terms of balloon to vessel size ratio, I think this is where imaging, of course, is important. You want to aim for one-on-one sizing. But of course, if you're not entirely sure how large the vessel is, then perhaps maybe undersizing it slightly like we do in general practice. If you're using a cutting or whatever, we don't want to cause any perforations, which haven't been seen as yet. So I think one-on-one sizing, and of course, if you use imaging, that is easier to perform.
Thank you, Johan. Maybe we can have a look at some real-world cases. So, Stefano, give us a great example how you used it.
Thank you, Valeria, and a big thanks to the company to kind invitation to show to you this case. So this is a case of eccentric plaque calcific plaque. This is a 79-year-old female with multiple risk factors with angina and normal function, but arrived because the CT showed to us a severe calcification on the circle, mid-circle, the big mid-circle, near to bifurcation with obtuse marginal branch. The other vessel seem good. In this situation, I believe that is important point. If you have evidence by CT, by angio, or if you have any problem to cross the lesion, it's very important to go directly with imaging to understand how is the calcium distribution, arc, etc. We do an OCT in this case, and you see the run that of the OCT, and you see in the zoom in the left of the screen the eccentric plaque. Here is easy. There is a virtual AI interpretation of the calcium, a big arc of calcium, thick of the calcium is near to 1.1. So at the end of this, we stop the frame imaging, and we see the very, very calcified lesion and tight lesion, and also the distribution of the calcium, also the thickness is high. The OCT evaluation, what tell us? Tell that is an arc of calcium 300, thickness is 1.1 millimeter, and the lesion length is not big lesion, but is a criteria to perform not a simple NC balloon, but to try a balloon specific device to modify the calcium. And my idea in this case is go to directly with the 3.0 LithiX balloon. And you can appreciate the balloon that arrived, a little bit friction. This is a real, and then we move a little bit, and the 3.0 advance into the eccentric plaque. And then I fix the step. We use the first inflation at 6 atmosphere for 15 seconds, and then you see appreciate the under-expanded, and then a little bit, don't move the balloon and more pressure. Then I move a little bit the balloon, and then at the 4 atmosphere, we have a complete balloon expansion. You see very well the hemisphere, and also the wire remain in the center line. This is important. We have a stent boost, we have a clear stent, a zoom intensifier lesion. That is important for us to appreciate if the device works. In this case works, obviously we also have an imaging. The concept is, repeat a lot, we use a hemisphere, obviously contact for all circumference of the lesion of the vessel lumen, but the action is in majority, and the bigger action is a very high stress against the calcium. This is the balloon inflation live, and then we appreciate a very well open only with LithiX at 10 atmospheres, and also we can appreciate an angio dissection, but very controlled dissection. Now we go to the OCT, and the OCT imaging show obviously the touch of the calcium from the media, and open very well. We don't need to see, but you see the measurement of the area increase a lot, more than 5 millimeter square, also in the distal portion. But if we put attention to the frame imaging, you can appreciate the macro or visible cracking, linear cracking. This is obviously this is a wire, but this is a footprint of the hemispheres. This is a first time that I see this. This is important because we see only the footprint, but like the animation showed before, under the footprint there is a micro crack. This is very important because if you need to up to more atmosphere with the NC balloon, this is the point where start the opening the plaque and also the lumen. Then we appreciate also the bend of the vessel, and then we finish with use a modular drug-eluting stent with a pot, and when with a kissing balloon to open very well in the big marginal branch. And also you can appreciate that after only the LithiX preparation of the vessel and implant the stent and post-dilatation with a pot and kissing balloon, the angiographic result is very good. And also the OCT confirm the circular well opposed in where there is a lot of calcium, and I believe that is a simple and educational example. Then this situation, when we move directly with a specific device, could help us to have a good result before to implant the stent. In other words, the LithiX, in summary, is a novel device with a multiple hemisphere, single point, I repeat, very high stress only in the contact point, and LithiX burst at the 12 atmospheres while respecting stepwise inflation for 10-15 seconds. And I believe that also another important thing is the size of this balloon. Soon as available, 2.0 and 1.5, also to prepare and then decide if we continue with this device or we move with other device. Thank you for your attention.
Thank you, Stefan. We're going to have a discussion at the end of the three cases. I think you excellent showed also in this case with a really, let's say, challenging takeoff of the circumflex, the nice deliverability of this device. So that's excellent. But Johan, we have some questions from the audience. Interesting, I guess.
Yes, just whilst the next speaker goes up there, in terms of having a jailed wire or having a buddy wire, that's not a problem. You know, you can wire a side branch and just use this device over it. So that's fine. The only kind of contraindication is to use it in a freshly implanted stent. That's not a good idea. Of course, older stents where you've got restenosis, calcified new atherosclerosis, certainly consider it there. But within a newly freshly implanted stent, I think we really should avoid using this device. So now we have Dr. Leibengut, who will give us a nice case of, or some cases perhaps even of nodular calcification. Thank you very much.
Yes, thank you very much for having me. I'm just showing you one case, but I would like to dig a little bit deeper into the physics of nodular calcium, because what I see and hear is sometimes not really what the physics reflect. So these are my disclosures. And I want to talk about this thing here. It's a nodular calcium that is out there in an otherwise healthy environment. And we need to get rid of it in order to place a stent and have full stent expansion. And this nodule is eccentric and it's also focal. And this poses some issues on the physical treatment of this lesion. So when we look at types of lesions and lesion morphology by intravascular imaging, ideally by OCT, because you can assess depth as well of the calcium and the composition, so you need to see a little bit denser and less denser areas. We will come up with those three morphologies. The concentric calcium, which when you have enough pressure usually cracks at one point of least resistance, so you just need pressure. Eccentric calcium is a little bit more difficult because you have this healthy part of the vessel which is extremely compliant towards the left side, and you would overstretch the healthy part, and it's always discussion about barotrauma to the healthy part of the vessel, and you reduce your pressure onto the calcium. There LithiX has a big advantage because of this extremely focalized pressure points, which you cannot make more focal than with the hemisphere. Maybe a needle would be, but that's dangerous. So the hemisphere is the most focal pressure point you can achieve. And if you have multiple of those, then your likeliness that at least one of them touches the calcium is very high. And that's why we believe it's so efficient in these types of lesions. And when it comes to nodular calcium, all these properties become even more complicated because your surface area is even smaller because you have a round circular blob of calcium. So your angle of attack or the possibility of attack, for example, of blades of cutting balloon, is less likely that your blade is exactly going onto that nodule. Whereas you have multiple hemispheres, it's much more likely that you have actually one of them or two touching really this blob of calcium. And at the same time, and I'll show you that later, it needs very, very, very high pressure. And when you have this small point of this hemisphere, is the highest pressure that you can achieve. And what has not been said, the balloon underneath is an NC balloon, so you can go to much higher pressure than with cutting balloons, which are semi-compliant, and then the amplification of the hemisphere achieves actually the highest pressure achievable in a vessel, about 80 atmospheres of pressure. So going back to calcium, which is basically unarmored concrete, when we crack the calcium, what exactly happens? You see it's actually cracking on the opposite side of the pressure point. So the calcium is not cracking where you have your balloon, it's cracking on the opposite side. And the mechanism behind is that calcium and concrete only cracks on tensile force. So if you pull on calcium, it breaks very rapidly. But when you push on it, so we're all standing on a concrete floor and it doesn't break under us, but if you would pull on it, it will break. So on the top, you have compressive force, and on the top, you have the tensile force, and that's how calcium breaks. Anyhow, you need some pressure. With the nodule, it's a little bit different. The nodule still breaks because of tensile stress, but you need a lot of focal pressure because you have a low surface and you have to get pressure inside. This is called the Brazilian test, and it's actually a true thing, and this is how they test these round things. And if you press from the top, you need, first of all, very focal and very high pressure, and you see this nodule splitting in half. The reason is when you press, you create a tensile stress on the side, and the concrete or the nodule and the calcium tries to pull outside, and then it breaks in half. And if you look at the formula, it's very complicated, but basically it's the tensile strength, how much force you need to rip the calcium apart, and it's the thickness of the nodule, and it's also the length, so the amount of calcium you have. Meaning, the more calcium you have, the higher pressure you need. And you can only achieve high pressure if you reduce the area of your pressure point to a minimum. The cushion would do nothing to the nodule. This is the semi-compliant balloon. It just massages a little bit the calcium, but it does nothing to it. The NC balloon increases the pressure, but still you have a large surface area, and nothing is going to happen unless the calcium is thin. And when you have thick and very dense calcium, you want to focalize your pressure to this area, and then also go high pressure, 80 atmospheres, and then your nodule will eventually split in half. And again, you only have this tiny spot, so you need a lot of hemispheres in order to increase your likeliness to really touch the nodule. And this is the case. Very focalized lesion. You can see the calcium, so you know that you need additional imaging to understand the morphology and then to decide what is the mechanism of action most likely to destroy your calcium. This is the plaque. Some people say this is a nodule. I would more say this is a rock of a small circumference. So it's not really defined what is a nodule. This is more plaque which has 180 degree of circumference. But I would really say that this is a true nodule. So you have very healthy vessel around, and you have this pebble stone that only has a very short surface, needs high pressure, and the very likeliness of contact. And as you can see, and if people are paying attention, this is Johan's case from before, but I think it's absolutely pretty. It takes time to get this together, but it's actually this round piece of calcium that is split in half, and at the same time was a little bit dislodged. So you see one half of the ball on this side and the other one on here, and it's completely fractured. And now you can press it into the wall with low atmosphere, and you will achieve a very nice, beautiful stent expansion. Most likely the surface area, the MSA would be enough in this case when you just balloon it because you overstretch the healthy vessel. But we also know that eccentricity of the stent is related to outcome. So we really want to split the nodule and expand the stent as round as possible. And you can appreciate that here on the stent. Of course, if you pay attention, you see a little bit of indentation there. So there is a little bit of remaining nodule, but it's not as much as you would achieve. And the MSA again and the eccentricity index was perfect in this case. This is a case 2, which I did just recently, and you can appreciate that the nodule is even bigger and more protruding into the vessel. And this was after 4 times inflating a 3.5 LithiX balloon, and I really can agree. It's very nice to move it. The refolding is quite good. You don't have, like with cutting balloons, blades that are interfering sometimes when you refold it and you use it multiple times. So it really goes nicely back and forth. And also there is no risk or fear of losing those hemispheres because they're actually embedded between 2 layers of balloon. So they're not really metal to calcium contact, so it's absolutely safe and you're not losing those hemispheres. And we had a very nice stent expansion. And again, I mean, this is the truth. You will not get rid fully of these nodules because they're just too much calcium, but you can appreciate that it was very nicely opened up and the MSA was great. And I would say its eccentricity index is really, really minimal. Pinnacle trials showed the same thing. We've heard it before. So nodules are actually treatable with this technology. And sometimes if they get too big, and you can still consider of using 2 devices, so maybe ablate a little bit and then come back with the LithiX balloon. You can even use the same one that you did initially because it has a nice refolding, and you can bring it back and you can inflate it multiple times and then eventually split those nodules in half again, because there is not only 3 hemispheres like in this image, there is multiple, and the chance of contact is really, really great. So this is what we want to do, split the moon in half, and thank you very much.
Thanks so much. I think that's a great demonstration of how to tackle the nodule. We're going to have the discussion at the end. I just want to mention that probably we saw in both cases, we're talking about non-eruptive nodule, because you could see at OCT that the cap was intact. And we also know that these are really challenging to tackle. These are what we call sometimes not deformable nodule. But it's important also to modify them, otherwise the risk of late events is particularly high. We have some question, Johan, I guess.
Yeah, just maybe as the next speaker is getting ready. Can we lose the hemispheres? No, is the question. There's a special. I'm not an engineer, but I've been told that there's a special glue that really has made sure that these hemispheres are embedded within the balloon. So we've seen no cases at all of loss of an hemisphere. And just to reiterate again, can we use it after stenting under expansion? Not acutely, no, but perhaps an implanted stent that's been there for a while, it could be considered. So yeah, it's a pleasure to announce now Dr. Buisset, who has a case of a long calcified lesion. So we look forward to hearing your case next.
Thank you, Mr. Chairman, and thanks to the company for this opportunity. So we recently in my institution had the opportunity to start working with this device, and I have to say that we got very excited, and I'm going to share with you one of the first cases that we did. Those are my disclosures. So briefly, this patient that we're going to look at is a quite old patient coming at the hospital for both dyspnea and angina, and for whom the examination revealed an aortic stenosis and renal dysfunction. So as part of the workup, we did a coronary angio that revealed a lot of calcium. You see here the RCA with a quite of diffuse calcified lesion, but that's not the point of today. Also in the circumflex system, quite a lot of diffuse calcified lesion. But what caught our attention actually was this long calcified LAD lesion, which looked somehow intermediate. So we made an invasive measurement that was positive, and we discussed this case in the R team and decided to treat this patient with TAVI and to do an LAD PCR. So again, I'm going to show you this LED, and you see on the left-hand side the coronaries without any contrast, just a fluoroscopy, and you see how calcified is this lesion. And on another projection, you see also the same pattern with here no contrast, and here with the contrast injection. So we did an IVUS to understand a bit better this calcified lesion, and basically what we saw that we had was what we had proximally and distally a nice spot to land, two nice spots to land, and in the middle, in between, a lot of calcium with distally actually the MLA with an arc of calcium around 270, and a bit above a concentric calcium actually with a probably quite thick calcification, and all along, as we saw in the angio, a long eccentric calcified plaque. So we went with the device to treat this lesion. Before that, we just advanced a small semi-compliant balloon to make sure that we could cross. And I have to say that I was also very impressed by the crossability, as it was mentioned by the previous speakers. Crossability was very good. And also in this case, what was really good for us is that we could apply different multiple inflation all along this long calcified plaque, first distally where we had this concentric calcium, and then pulling back the balloon, doing multiple inflation all along this long calcified plaque, progressively with not so high pressure, leaving the time for the balloon to work. Then after that, we did a control shot, and as it was previously mentioned, we had, of course, no dissection and no problem on this intermediate shot. And we did a non-compliant predilatation. And what caught my attention actually at the time of the predilatation with the non-compliant balloon was looking at the balloon itself. The expansion of the balloon was completely concentric. You see the wire is in the middle, which is quite, in my experience at least, quite difficult to achieve in eccentric calcium, because very often, as it was also explained previously, very often you push towards the healthy vessel and you don't do much on the eccentric calcification. And in this case, it seems that we were able to modify the compliance and to get a concentric expansion of the balloon. So we thought that we were ready to stand, but beforehand we did a new IVUS. These are the pre-IVUS, and I bring you here for you the post-preparation IVUS. You see that at the level of the MLA, we had a significant gain of surface, and at the level of the concentric calcium, we could see several fractures showing that we could break this concentric calcium. At the level of the eccentric calcium, I have to say that I didn't saw much modification in terms of calcium, at least with the IVUS, but I was happy with the concentric expansion of the balloon, so I decided to go for the stenting. We put two consecutive stents in this LED, and I have to say that we were quite happy with the final result. I'll let you appreciate on the left-hand side the IVUS pullback, and I took for you some cross sections. The MSA was 6.3, which was more than 100% stent expansion distally, and proximally we got a MSA of 9+ millimeter, which was also we think quite a good result for our patient. So, in conclusion, and based on our experience, which is quite, which is still a bit limited, this is our final result, which was I think fine. What I learned from my first cases is that it's definitely a device very easy to deliver. We did also more challenging cases, and it was easy to push down the balloon. We should keep in mind, because the difference compared to other IVL devices is that you don't have generator. It seems that you have a normal balloon, but you should keep in mind that it's an IVL balloon, so you should take your time to do the inflation slowly. Don't need to achieve 20 atmosphere. You can start at 6, 8, 10, 12 max, and leave the balloon work, let the time to the balloon to do the job, and use the pressure as mentioned by the constructor, I would say. What I was willing to learn, and I learned along this session, that this is actually very interesting device, because as it was explained by Gregor, we have different morphology of calcium, and very often in the same patient we have different morphology in the same vessel even. So a device that is probably able to tackle all these morphologies for me really interesting and seems very promising. Thank you very much.
Thank you very much for a very, very nice case. So there's some more questions from the audience. Please also use the mic if you want to. I will ask Stefan a question in a moment, but I just want to reiterate what I think about this device, which makes it really useful. It's really, the learning curve is very easy, and especially in the cath lab, if you have to go for rotablation or orbital. I know my nurses kind of frown, oh, here we're going, we'll be busy for another hour and a half, 2 hours. So I think it really is has a low threshold to use it and is easy to use, but still, we have to use it correctly, Stefan. So I was just wondering, are there any things that we really should consider as an operator and to achieve the best result with this LithiX device?
Thank you, Johan. I believe that a lot of things already have been said here, but let me summarize. I would say for the first, I would say go low and slow. That means that you don't have to go to high pressures immediately. You start at 5 atmospheres, and actually the balloon can already do the job at 5 atmospheres, but you can take it up slowly. You take 1 atmosphere per second, up to 5. You can go to 12 atmospheres. I know people have used it up to 20 atmospheres, but the rated burst pressure is 12. And you need to go slow because you need the time to allow the pressure or the balloon to do the job, to propagate the fracture and to initiate the stresses that are so important. That's one, go low and slow. Second is apply multiple inflations. I think it's important. Use the technology that is in the balloon, meaning you have several rows of hemispheres. So you need to use them. So if you go 3 to 5, you deflate, you inflate again. You know that the hemispheres will be in contact somewhere else in the vessel, and this will maximize your percentage of fractures. You do several times. And then third is that you can use variable pressures and inflation time. You can keep it short, you can keep it long, but as long as you hold it, the more pressure you will build up, the more fractures you will create. That's basically, I think, the 3 things that I would like to summarize.
Yeah, go ahead, sir.
Thank you for this nice presentation and impressive device.
Microphone near to the mouth.
Okay. Thanks for the nice presentation. I want to ask about some technical issues in my mind. I have some concerns about that. We have some hemispheres on top of that balloon device, and when we are thinking about folding, it should be a bulky device when you fold them because they are having such hemispheres on top of that device. So it will be worse when you are sending the device to the lesion, especially in tight and long calcified lesion. But when you inflate it, then you open it up, and then you deflate it and use several times. But while you are pulling it back, it will not come back easily, because maybe it will touch to somewhere and you have the chance to lose that hemispheres inside the vessel. And the second thing, for example, when you increase the pressure, the hemisphere will touch to the vessel wall, especially to the calcification, but the circular parts of the hemisphere will tend to rupture because it contacts with the balloon when you increase the pressure. I mean, the rates of rupture, rates of creating a perforation or losing the hemispheres, and while you are pulling back the device, you should have an inside movement of the guiding catheter in terms of creating a dissection. What are the technical issues?
Well, thank you very much. I mean, very pertinent questions. All of those questions, thank you very much. These are stainless steel hemispheres, so they themselves can't rupture. I think just in the Pinnacle 1, but especially also with people on the table, at the table here, who've been using it in very complex cases and even more than this, it hasn't been an issue. Even when it folds in, it's easy to retract. You'll have to ask the engineers how they managed to do that. I'm not sure. But so we haven't seen any hemispheres dislodge or disappear either. So it seems to work very well. I've got a question for Gregor here, because I think you managed to convince them about the nodules very well. Somebody's worried that we might do such a good job, the nodule might embolize down the vessel. Could that happen, or would you be concerned about that?
I mean, never say never, but I don't think so, because this is what my patients always ask me: what happens with the cracks? And I tell them, you know, if you take a vase and you put tape around it and you drop it to the floor, the pieces will not shatter away. It will stay in together. And this is how it's also in a vessel. The calcium is not by itself. It's part of the tissue. And if you look at histology, you see collagen around going through the calcium. It's part of a whole vessel structure. So when you split it in half, it's not going to be pieces embolizing. So, and also this is what I see with the few nodules that I split. It's still attached to some collagen, so some tissue, and you're not dislodging them. And I can also add something to the hemispheres. So I, of course, take all the tools apart, and some people in here know that I break everything on the table before I put it in a patient. I also did microscopy of the LithiX, and it really looks like it's just like embedded within the balloon wall. And I even try to scrape them off with some scalpels, and you cannot really scrape the things off. So I'm 100% sure there is no clinical scenario where you pull it through a tight lesion or something that you scrape off and you lose those hemispheres. They're dead on. So I would start distally, like you stand, and go proximally, because otherwise you end up, the company likes it maybe, you would end up 4 devices because you cannot advance it, and then you have to inchworm your guide extension down, and you get all these troubles. Just get it down, it's a good crossing profile, and then start ballooning from the distal to the back. And I promise there is no hemisphere going to be lost.
Thank you very much. It seemed very excellent. Very excellent. This is for me?
Yeah. Yes. Okay. Go ahead. It's for you.
Thank you. This is an excellent technology. In fact, I have never used those bulky, fracture to fracture the calcium like lithotripsy, or shock lithotripsy, or rotablation, because it is very complicated. It needs a lot of time. It is very threatening for the patient. It needs a long time, learning curve. I appreciate that this device probably the one which can be done by an interventionist who's doing stenting. But my question here, we know the diameter is different. You have different type of diameter to go for different size of the vessels. But how about the length? It is one length or multiple lengths?
Yeah, no, it's 14 millimeters. So it's one length. One length. Yes.
No, it's one length, but it's different sizes. So it's one length, as John said, but different sizes. And you can also, if you're worried about, let's say you have a 3.0 vessel and you're worried about going with the 2.5, you can also start with the smaller one. And this is usually how we do it. We take a small one and then we go with a bigger one. One thing I wanted to emphasize, it has been said before, time. This is our worst enemy. We go in with the balloon, we inflate them, deflate them, and out. There is data that it takes 15 seconds in order to have the pressure that you have on your inflator to be present in the balloon on a steady state. And there is also something else, it's called creep effect. If you hold pressure on concrete for a minute, for 2 minutes, it will break eventually. There is this Ponte Morando, a bridge in Italy. It was very well constructed, but at one point it broke because there were so many cars going by, and it was over time creating cracks, and they propagate and eventually they break. This is the same thing in calcium. So please take your time, inflate and wait 20 seconds, 30 seconds, and you will see how your pressure goes down, and you can readjust the pressure, and your success rate goes up tremendously.
Yeah, go ahead.
Yeah, just one question. Great technology. We should try and see how it's work. What happened? Sometimes it's also with 4 or 8 atmosphere. We have a rupture of the balloon. Just a question: if someone tested for the hemisphere, or it's
so the rate of burst is 12 atmospheres, but actually within the pinnacle we haven't seen any ruptures at all.
Just make that. It's a rupture. Yeah, you don't have it.
Oh, but make it
60
rupture.
patient, you don't have it. You're perfect. But if it's happened,
well, apparently it ruptures along the length of it. So it doesn't go outwards. It goes along the length, according to the engineers. But that's what we've been told. Yeah.
Okay. But you never try to
Not personally.
Try it and see what's happened.
Okay, thank you.
Let's have some closing remarks. I think it's great to see so many questions via the chat, and also, as always, in the last 10 minutes, everyone want to ask questions, but you can pose questions later on also to people by Elixir. So some closing remarks. I think that should be the workflow, so bear that in mind. Achieve, first of all, good pre-dilatation in order to have an inner lumen of at least 200. Of course, we need to understand what's going on there. Intravascular imaging is key to guide your procedure. And then the aim is to size your device, so the device to artery ratio is 1:1, and optimize with a non-compliant balloon. As we said, up to now, low and slow inflation. Don't rush. So start with a really nominal pressure, which is 5. Maintain that inflation for a few seconds in order for this hemisphere to propagate the energy throughout the whole surface. Then take advantage of multiple inflations, because in this way you can be sure that you can tackle the whole calcified surface, and in order to have multiple points of contact and cracks. And then if you're not satisfied with your result, either controlled intravascular imaging preferably, or checking the angiographic expansion of your balloon, go higher with the atmosphere, and you can go up to 12 atmosphere if necessary. That's the rate burst. To summarize, the Pinnacle first trial results demonstrate an effective and safe calcium fragmentation with LithiX IVL device across multiple calcium distribution, eccentric, concentric, also nodular lesions, a great achievement of stent expansion, and it's really efficient, can be easily integrated in your PCI workflow. Thank you.